Welcome to ATCM channel. Shall I start?
Yes.
A 66-year-old male presented to ER in the evening hours with complaints of headache from morning onwards. On initial 10-second assessment, patient conscious and oriented, obeying commands, airway was patent, breathing, respiratory rate is 18 per minute, saturation 99% in room air, circulation, BP is 130/80, pulse rate is 86 per minute. Coming into airway was patent, breathing, respiratory rate is 18 per minute, saturation is 99% in room air, circulation, BP is 130/80 mm of Hg, pulse rate is 86 per minute, all peripheral pulses are equally palpable. Coming into disability, GCS is 15/15, pupil is bilaterally equal and reactive. Exposure wise, temperature is 98.6 degree Fahrenheit and GRBS is 127 and the pain score was at that time is 8/10. At that time we cannulate and give paracetamol 1 gram IV stat. And since the patient and we took headache.
60 age?
66-year-old. Sample history, a 66-year-old male patient, non-case of...
Surveys, no.
It's clear. 66-year-old male patient, non-case of systemic hypertension on medications, complaints of acute onset of headache from today morning onwards. Moreover, the right frontotemporal region, unilateral and throbbing type of pain without any radiation of pain, associated with nausea and one episode of vomiting. Pain slightly decreased after oral analgesics and again reappeared and persisting for the past 3 hours and associated with photophobia. But there is no history of flashes of light, numbness or paresthesia, rings or spots. History of decreased sleep during the night due to work stress, and also history of similar episodes of headache in the past over 1 year over the same region. No history of fever, neck stiffness, rhinorrhea, nasal congestion, neck stiffness. No history of altered mental status, blurring of vision or facial deviation, weakness. No history of trauma, no history of weight loss or night sweats, no change of headache while bending, lifting or cuffing. No history of any allergies. Medication history, the patient is systemic hypertension and was on losartan 40 mg BD. And personal history, patient is non-alcoholic, non-smoker, no history of drug abuse. Last meal was at around 4 p.m. And general examination, no pallor, icterus, cyanosis, clubbing, lymphadenopathy. No family history of similar.
Any substance abuse?
No history of drug abuse. General examination, no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. On systemic examination, CNS, GCS is 15/15, E4M5, E4 V5 M6 and pupil is bilaterally equal and reactive. And examination of head and neck, ear was normal, no sinus tenderness, throat is clear, no neck stiffness or tenderness palpable, no scalp tenderness or tenderness over the temporal region. When coming to the higher mental functions, it was normal, orientation, memory, intelligence and speech was normal, and cranial nerve examination also completely normal, reflexes 5/5. After examination, we come into diagnosis of common migraine.
Okay. So in ER, what are the general mention that headache comes to ER? So what are the differentials that you should be keeping in mind? What are the remedies for headache?
Headache can be differentiated into primary headache and secondary headache. Primary headache without any non-etiology, and secondary there will be an etiology. In primary headache we can consider migraine, tension headache, cluster headache, and we can also look for medication overuse headache as primary diagnosis. And as secondary diagnosis we can think about subarachnoid hemorrhage, meningitis. Secondary headache. We can look for meningitis.
Migraine, tension headache.
Cluster headache, migraine, medication overuse headache, trigeminal neuralgia and all. In secondary headaches,
what medication overuse?
NSAIDs, opioids, triptans, paracetamol overuse. If it is paracetamol, NSAIDs and medication overuse for the past 3 months and more, there will be medication overuse headache will be the
So withdrawal of that
withdrawal of the drug
is the treatment for?
The medication overuse.
Yeah.
Headache.
This medication overuse headache. Okay. Then migraine, tension headache,
And cluster headache.
medication overuse headache. Then
Exertion headaches also can be DD, trigeminal neuralgia.
Okay.
And
How do you differentiate between?
Sir, in
And you
tension,
told secondary headache also. So what are the causes of secondary headache?
secondary headache can be due to meningitis
There is a
associated with
specific reason
fever.
for
Specific
secondary
reasons.
headache. So what are things? Meningitis?
Meningitis, subarachnoid hemorrhage can be a cause, and also any tumor dissections, space occupied lesions, and also in case of glaucoma,
Acute angle glaucoma.
and carbon monoxide poisoning and all. There
Carbon monoxide poisoning. Okay.
temporal arteritis,
Also called giant cell arteritis.
giant cell arteritis,
Sinusitis.
sinusitis.
Then
Low CSF pressure headaches can be the secondary.
okay. Idiopathic intracranial
Hypertension.
Okay.
Pseudotumor cerebrae can
Pseudotumor
cerebrae.
cerebrae. Yesterday we saw a case with a patient came with had a history of polycythemia. Came with headache. Yesterday we saw. Okay. In that case, we should follow what is the treatment?
Vein section, phlebotomy.
Okay. Then what is? Headache. Patient has been walking all outdoors in sunlight. Came with headache, vomiting. Nausea. Porphyria. Sunlight and all. Heat stroke.
Heat stroke.
Can person with headache. Then, if patient is on what drug will cause headache?
Calcium. Nitroglyceride and teacher.
May cause headache. Okay. Then recreational drugs. What recreational drug?
Amphetamine,
Cocaine.
cocaine.
Amphetamine. All these things can cause headache. So there are many
Reasons.
for headache. Then functional. Psychiatric causes. Patient may not be having headache, but then how do you differentiate between a migraine, cluster headache, tension headache, and all?
Usually in migraine,
In
it
this case,
is
you told it's somewhat like focusing with the
primary headache.
Because what are the red flags for this thing?
If it is a new onset headache in an elderly, more than 55 years of,
So the red flags means in the cases in which you should be more alert, you should be doing some imaging,
Investigations.
further imaging to rule out other causes, other major causes for headache. So what are the
new onset headache in an elderly, and also thunderclap headache, that is the headache which reaches its maximum intensity within 5 minutes, and if there is a change in the pattern or intensity of the headache in people already have headaches, and also if the headache is associated with loss of consciousness, altered mental status, any weakness of limbs, and if the fever is if the headache is associated with fever, neck stiffness, we should suspect meningitis. And if the patient has headache following an exertion, weightlifting or something, we have to rule out any structural brain lesions or any bleeding, SH should be ruled out.
Any change in the CNS, any change in memory, any cognitive
neurological
dysfunction, any neurological deficit, nausea, vomiting, result of vomiting, change in the pattern
of
headache, and the patient is already on some oral anticoagulant, aspirin, all of us are developing headache. We should be cautious because it can be a bleed also. Then if the patient has got some oncology,
malignancies,
then you should be careful. It can be a brain mets also, maybe causing a raised intracranial hypertension because of some metastasis. You should be knowing which all malignancies will cause metastasis to the brain.
The different types of migraines are there: migraine with aura, without aura, and hemiplegic migraine, and also ophthalmoplegic migraine and basilar migraine are the different types of migraine.
So how do you differentiate between migraine? Primary, right now the diagnosis is primary headache. How do you differentiate between tension headache, cluster headache?
Tension headache is a more like a band-like headache over the frontal temporal region. It's a band-like. It's not unilateral.
So the
Band-like
sensation then?
more during 4 to 6 hours, and
How does it precipitate?
precipitate by the stress, sunlight, and all.
Means what?
Emotional stress and tension.
Something else. Even sleep deprivation.
It's a deprivation, emotional stress.
All these things. Okay.
And in cluster headache, it's
So what is the treatment for tension headache?
we can do yoga exercises and all along with analgesics.
Emergency you can't do all this.
Analgesics and along with yoga exercise and
Analgesics, what you?
paracetamol, NSAIDs.
NSAIDs and
Paracetamol.
And what about this thing? Migraine?
Migraine is it's a kind of a unilateral throbbing type of pain lasting for more than 5 to 72 hours.
What are the different types of migraine?
Migraine with aura, without aura, and there is hemiplegic, ophthalmoplegic migraine, and also basilar migraine. That are the 5 types of. With aura, we
Migraine
can
with aura, without
with
aura.
aura, hemiplegic migraine, and ophthalmoplegic migraine, and basilar migraine.
Okay. Then?
The cluster headache is likely to seen in mid
How do you
20s.
treat migraine?
Migraine can be, the first line treatment will be analgesics, paracetamol, and also we can give NSAIDs. And first line treatment is analgesics with paracetamol, NSAIDs, and we can also give sumatriptan. Triptans can be given. Sumatriptan 50 mg, 100 mg can be given. And also we can treat if the headache is associated with vomiting, nausea, vomiting, we can give antiemetics like metoclopramide and domperidone can be given. And there is a triptan is the most specific treatment. If it taken early, it will be more beneficial. The headache will subside soon. If not respond, we can give ergotamine tartrate up to 1 to 2 mg can be given. That's a treatment of migraine.
Cluster headache?
Cluster headache is more like,
How do you differentiate between cluster headache and
it's usually seen in mid 20s, associated with unilateral eye pain, nasal congestions, and moreover
cluster headache?
cluster headache.
Maybe it will be around 20,
mid-twenties,
25, that range. Mostly men. More than females, it's males. And then
So unilateral eye pain will be there with nasal congestion and autonomic symptoms, lacrimation and
lacrimation,
rhinor.
then
Swollen eyelid and
swollen eyelid,
Caucasian clusters.
meiosis,
Uh,
meiosis,
drooping of eyelids
drooping
and
of
all.
eyelids. So how do you treat that?
Mainly with analgesics.
Where do you give oxygen?
We can give high flow oxygen also.
Within migraine or
Cluster headache, cluster headache.
Cluster headache. Okay.
High flow oxygen can be given, and also sumatriptan
How much
15, 12 to 15 liters of in a
NRP, 12 liters, right?
12 liters.
Because I think you have gone through the nice guidelines for headache.
High
I
flow
think
oxygen.
headache treatment, a nice, I've given a separate guideline how to treat these kind of headache. And if you are writing the MRC and examination, they'll ask what is the first line of treatment for cluster headache, or else they'll give a scenario in which scenario will be cluster headache, and what is the most like first line of treatment for this scenario. Okay. So based on the scenario, you should understand whether it's cluster headache or migraine or tension headache. And first line is oxygen, 12 liters. One option will be 12 liters of this thing with NRP. Second option will be NSAID. And third option will be paracetamol. Like that. Then
Sumatriptan.
Like that. If you don't know the diagnosis, the entire this thing will change. Alright. And then after oxygen?
Sumatriptan can be given 6 mg subcutaneously in this case.
In migraine, it was
Well, it's oral.
50 mg or 100
100 mg oral.
orally. Okay. This is subcutaneous.
Subcu.
And where do you give that nasal triptans? Migraine between 12 to 17 years, nice. I think I mentioned
Nasal
triptan can
triptan given.
be given. Okay. Then
These are the primary headaches.
what are the migraine? What are the aura that the patient may usually come to you?
Flickering lights can be seen. Numbness, paresthesia
Numbness, paresthesia,
can be one side. Flickering lights, flashes of light. Flashes of lights.
scotomas. Okay. From unilateral area, the some vision loss. Then silvery zigzag.
Seconds.
Okay. Then how long will this aura last for? Usually, to call it an aura. Usually it resolves within 16 minutes.
16.
Okay, it won't last like forever. Okay. Then some pins and needles sensations.
Paresthesia.
Paresthesia,
Numbness.
numbness, all these things can happen. Okay. Then, what is the age group usually seen?
Migraine more commonly seen in women less than 40, around 40 years.
40 years.
Yes.
Okay. What about trigeminal neuralgia?
More
How is the presentation like?
the sharp shooting like a pain in the trigeminal region, supply region.
This area, right?
Yes.
So we have got 3 branches:
Ophthalmic, maxillary and mandibular.
It will be like a
Sharp shooting like
lightning
a pain.
kind of
Lightning kind of a pain.
pain. Okay. Then, what is the treatment for that?
Trigeminal neuralgia, we can give carbamazepine, phenytoin, valproate, lamotrigine.
Even temporomandibular joint pain or any toothache, any infected this thing that can present as
Headache.
and even sinusitis. Acute sinusitis can present as headache. How will chronic sinusitis usually present? We have got sinusitis acute and chronic. Chronic sinusitis usually will they present with severe headache and all?
Usually not present.
So what is the usual presentation? They will have some sort of
Nasal
bad
content,
smells.
that's-
They themselves will feel that it's bad. And if you go towards them, you can feel the smell. That bad foul odor. That is called chronic sinus. Because of some irritant, some chemicals or something, the patient will have been probably some been exposed to some chemical agents, and chronic irritation for years together will cause this kind of sinusitis. It's called chronic. They don't usually present with headache. What about temporal arteritis, giant cell arteritis? How is the presentation like?
It's a unilateral kind of pain over the temporal region.
Yeah.
Here, where the temporal artery resides, and there will be mild thickening of the temporal artery, and we can confirm it with the temporal artery biopsy.
So you can feel that temporal artery pulsations.
Torches, tenderness, torches and tenderness.
Okay, tortuous, you can see like that. Tortuous vein, you can see like that. Artery, sorry. Tenderness will be there. Usually it involves all medium and giant arteries. More than 50 years. So what is the treatment for temporal arteritis?
Steroids can be done.
On what steroid you get?
Methylprednisolone along with
How much? 68.
16.
Then You read these guidelines on something more to add on?
They write about the where should we take non-contrast head CT and MRI brain with or without contrast. So in non-contrast head CT we can take in case of trauma, thunderclap, headache and no headache.
Thunderclap headache is suggestive of what?
It's any bleed or SH.
Subarachnoid
hemorrhage.
Sudden. Simply that suddenly it feel as though somebody has beaten. It's about SH.
Trauma, thunderclap, headache, new headache plus focal neurological deficit or papilledema, chronic headache plus change in the frequency and pattern of the headache. MRI brain with or without contrast we can take in case of new onset headache with focal neurological deficits, papilledema, possible encephalitis and all, vertebral or carotid dissection. And in case of patient with cancer or immunocompromised patients, in case of intracranial hypertension and no onset headache in pregnant women and all. And mainly in pregnant women. And the investigations mainly depends upon the characteristic of headache, age and comorbidities of the patient and the presence or absence of focal neurological deficits. And also they talk about the exertional headache which followed by weightlifting, running and even during the sexual intercourse and all, and following coughing, sneezing, straining with bowel movements. In that case, if there is recent onset of headache related to excision, we have to take the urgent MRI to exclude any structural brain lesions or any bleed.
Okay. Usually post-exertional headache can be because of a post-defecation or sudden headache and all, can be because of should be careful.
And in case of trigeminal neuralgia, it is more seen in 50 to 70 years and it is idiopathic and electric shock like pain, and it is triggered by minimal stimuli and there won't be any neurological signs in case of trigeminal neuralgia.
So that is one point, no neurological signs in case of
trigeminal neuralgia. And in that also there is best predictors of migraine, and they show a mnemonic like pounding, P for pulsating, O for the hours, 4 to 72 hours, and U for unilateral, N for nausea, and D for disabling. And
this is as per NICE guidelines.
And Arkham learning from the Arkham learning. And also they discuss about the types. The migraine with aura, there will be visual disturbance develops over 5 to 20 minutes and resolves within an hour. And migraine without aura is known as common migraine. And here in ophthalmoplegic
migraine is without aura.
And ophthalmoplegic migraine, acute third nerve palsy. There will be dilated pupil with unilateral eye pain. And in basilar migraine, severe headache preceded by ataxia, vertigo, nystagmus, diplopia, and reduced level of consciousness will be there.
So the thing is, it can be migraine. This, what you said in the last, can be tricky. Even IC bleed can present like that.
Okay.
So in the emergency department, if such a case comes in, if you are in a dilemma whether it's really migraine or if it is something else, bleed, it's better to do an imaging in the first instance itself, rather than taking a risk and waiting for the things to get subside. By that time, bleed would have extended further and then it's not salvageable. So rather than missing the diagnosis, I think it's better to do imaging. Even though NICE guidelines say do not overuse imaging techniques and all. But on the safer side, in India, it's better to do. Okay.
That's
What about pseudotumor cerebri? How would you? Because of what to do? To drain the CSF, to relieve the pressure because of raised ICP because of no reason, right? To drain the CSF or use some anti-edema measures to decrease the intracranial pressure. Okay. Anything more to add on? Sinusitis, how will you treat acute sinusitis?
Anti-inflammatory.
Apart from analgesics.
You can give anti-inflammatory.
Antibiotic also is amoxicillin, guaninic acid, one course you can start. And one In chronic sinusitis, what will you do? You can try with the better. You can try with the decongestant and some nasal wash or nasal wash apart from augmented one shot, and then you can refer them to ENT specialist. Nothing more to add on. In this case, CNS examination is you should do a proper CNS examination and then come to the proper diagnosis. Okay, thank you.